Welcome to Conversations in Interventional Cardiology. My name is David Rizik. I'm the Associate Editor of SCAI, and I am the Chief Scientific Officer at the Honor Health Hospital System in Arizona. And I am honored to represent SCAI and especially SCAI Editor-in-Chief, Dr. Alexandra Lansky. Today is an important topic. We're here to discuss a recent survey published in SCAI entitled Occupational Health Hazards in the Cardiac Catheterization Laboratory, Results of the 2023 SCAI Survey. And we have an all-star panel. I'm joined by an esteemed group of leaders in this field, Dr. Abudayyeh, Professor of Medicine at Loma Linda in California, Dr. Andrew Klein, interventional cardiologist, and one of the national leaders from Piedmont Heart Institute in Atlanta, Georgia. And someone who really needs no introduction, Dr. Jim Hermiller from Indianapolis, where he's the director of the Interventional Cardiology Fellowship, and he is our SCAI president. Gentlemen, thank you so much for joining me. And I'm going to turn it right over to Dr. Abudayyeh. Tell us a little bit about this publication.
Thank you, Dr. Rizik, and thank you for the kind invitation. So this was a project that was put together by the SCAI leadership, and they underwent the study as a follow-up to the prior survey, approximately 2014, and a prior survey before that, 2004, as part of the commitment by the Society for Physicians and Staff's Well-Being, and to mitigate the injury, look at the injury, and then develop approaches to mitigate the injury for it. So the occupational health hazard has long been something that is of concern to people in this field, in interventional cardiology, as well as other areas that primarily work in the cardiac catheterization lab, not to mention other labs that work with radiation. Of course, they have to wear protection, lead shielding, and so on. So this survey was put together for 2023 as a longitudinal survey to follow the 2014 survey. So the background is that we know that volume and complexity of procedures in the cardiac catheterization lab continues to increase. Occupational hazards in the cath lab include obviously radiation exposure, as well as, of course, the injury related to heavy lead apron wear, as well as the awkward static posture, especially as you consider the more complex procedures we do now, such as the structural interventions, peripheral interventions, and what have you. Stress and personal strain. We're all well familiar with on-call sleep deprivations and complications and the stress that goes with that. Those are areas that SCAI has been especially committed to, and there's been a series of webinars focusing on those as part of the Physician Wellbeing series. So SCAI conducted a survey of the membership examining the impact of these hazards in the cardiac cath lab, which has repeated many of the questions from the previous survey in 2004 and 2014, but with additional questions primarily related to pregnancy as well as mitigating factors that look at what can we do to mitigate those injuries. So this is a brief background of what the survey respondents looked like. There were about 300 respondents, varying in age everywhere from between 30 and 70, predominantly men, which reflects the population of interventional cardiologists. We're hoping to see that shift, of course, and years of practice has been fairly evenly distributed. For the most part, the respondents have been interventional cardiologists, knowing, of course, that we know that everyone in the cath lab is affected, more so the people that we don't traditionally consider, such as imaging, cardiologists, and anesthesia. And this is the result. This will be a very short overview of the article that obviously is published in SCAI. And in terms of occupational impact, we have the respondents reporting that 28% of pregnant women, for example, have been discouraged from working in the cath lab due to being or considered becoming pregnant. And 71% would consider stepping away from the cardiac catheterization lab at some point during this pregnancy. Radiation injury was especially, at least to me, surprising in that it actually increased in the 2014 survey results. There were 6% diagnosed with cancer, 5% diagnosed with cataracts, and 5% with skin diseases. What is even more impactful is that this is direct respondents. This is not reported respondents of people they know. So colleagues of staff, the numbers were even more striking. Orthopedic injury was 66%, 34% reported lumbar injury and spinal injury, and 25% reported cervical spine injury. What's striking again is that this is personal reporting. So for example, lumbar injury was 63% as opposed to 34% of people who know someone who's had that injury, and so on. And what is also more striking is that these numbers have slightly worsened since 2014, so they're certainly no better. So what are the consequences of these injuries? Well, 17% decided that they were either going to or required to limit cath lab hours to reduce the radiation exposure. 19% have actually eliminated or limited their work in the cardiac catheterization lab, which, as we know, there's already a shortage of interventional cardiologists. So limiting your operational cath lab work is especially costly from both the patient outcome as well as, of course, the financial outcomes to the facility. 20% have had to take a period of absence from the cardiac catheterization lab due to physical illness. And of course, that goes back to the injuries that were reported. And 3% have taken a period of absence from the cath lab due to mental and stress. And this is especially striking considering that the numbers were fairly high. The people who reported, for example, that they had to limit cardiac catheterization involvement were upwards of 81% due to orthopedic injury. So these are certainly fairly striking. And the issues are real. There's substantial impact, and the apparent that the interventional cardiac lab is not a safe and healthy work area. SCAI is therefore committed to looking into that. So the current use of radiation protection as a mitigating option includes, of course, the spectrum all the way from leaded eye protection down to newer emerging technologies such as shielded, full shielding that is covers the operator without actually having to weigh them down with lead, such as Rampart zero gravity and so on. So the adoption rates, however, are fairly heterogeneous. So it goes all the way from 67% as the best adoption all the way down to the single digits. So even the most commonly used protection is only 67%, and that's eye protection and hanging shields, which come standard in most cath labs, which quite frankly is not ideal. I mean, we should be closer to 100%. And few labs utilize reduced lead and overall radiation protection technologies that don't weigh down the operators. So why not? What is it that's stopping us from doing that? Well, perceived barriers to enhancing cath lab safety range. Principally, the respondents have reported that it's the cost, administrative buy-in, and operator limitations. As we can see, it goes all the way down to not having any barriers, but that's in the single digits. But the perceived cost and administrative buy-in, not to mention, of course, operator limitations and learning curves, have been at least perceived by the respondents as the substantial barriers to adopting technologies that can definitively reduce our radiation exposure, not to mention orthopedic injury. So what is the desired action? Well, there are areas where societies such as SCAI and others, in partnership with state and federal regulatory agencies, can help. One of those is advocacy. We need to challenge the current approach, shift the paradigm away from wearable to non-wearable protections, and make this front and center a priority. No other occupation allows their members to get away with this sort of exposure and injury. So it is incumbent on, I think, the society and the operators, that's us, to take the role of advocacy on our own behalf. Education, obviously, is an issue, education on musculoskeletal injuries. And it is so prevalent that 2/3 of all operators have either personal experience to have very close experience with operators next to them who are no longer able to operate at their capacity due to orthopedic injury. Understand the role of ergonomics. Obviously, employment policies have to follow suit. Unique health and disability benefits, institution of safe and effective protective measures, and in the case of pregnancy, radiation safety education, injury protection education, and at the end of the day, it should be the operator's choice, the pregnant person's choice of how she would like to proceed and how to mitigate her own injury. And thank you for the time.
Wow, that's terrific and very timely and extremely important. Herms, I'm going to turn it right over to you. You have been one of the pioneers and the tip of the spear on this. I've heard you quote the very thing that Bob Riley said in his editorial: you can't properly take care of others if you're not taking care of yourself. And I've heard you say, if this were Ford or General Motors, they'd have shut this down by now. Shouldn't this do it? Shouldn't this be enough? Shouldn't these data be enough to get hospital systems, state agencies, even our national agencies and our societies to mandate a safer environment and mandate both a lead-free environment and zero radiation?
Thank you, David. You've been at the tip of the spear, and I've been your wingman. So this is such an important issue, and what strikes me most about this, we haven't made a lick of progress in 20 years. With all the incredible technological advances in what we do in the lab, we haven't done anything to protect ourselves. So this just drives that point home. And I think another point here is that often we're very concerned about the radiation exposure, as we should, but nobody realizes the occupational and career-ending issues related to the orthopedics and the spine. And there's a tenfold increase in spinal injury compared to controlled match people not doing what we do. The same thing with lumbar; it's threefold higher. So I think what this paper does, and Islam presented it beautifully, is it lays the groundwork and shows it what the problem is. It's enormous, and it's not just the doctors, it's the nurses, it's the staff, and it's not just interventional cardiology, it's all subspecialties that work in fluoroscopy. Your question is, isn't this enough? You would hope it was enough, but we need to do more, right? This is just, I think, one of the foundations. I think clearly have outlined the problem. What are the solutions that everybody can really benefit from these new technologies that will reduce our radiation to near zero or zero, and then get us out of these heavy lead aprons that protect us, but unfortunately come with a high cost. It's gonna take a large coalition, all of us that work in fluoroscopy labs, industry, those that are in charge of really X-ray and nuclear regulatory agencies, and then we're going to have to really advocate on Capitol Hill as well as administrative approaches to really move this needle. And I think we at SCAI have all of those things underway. This is a multi-pronged effort. We're going to put together when the SCAI May sessions, scientific sessions come together, we're going to have really a summit, and we're going to have all the stakeholders there. And at the end of the day, we have a plan, and we're going to execute it so we can be safe, we can be healthy enough to take care of those patients that we all care so much about.
Yeah, Jim, what I really appreciate from the minute you took over the presidency is you didn't just conceive of a plan. This is a plan with substance. However, let me ask you a question, Andrew. What do we make of an 8% response rate? That seems low to be truly representative of interventional cardiology in a society as widely, hopefully, representative as SCAI.
I think the issues that we have for a response rate is, not understanding the importance of this project. I believe somebody might have said it's not only a goal to get out of the lead, it's a moral imperative to get out of the lead. I believe you said that exactly. And I think that's what we need to do. We need to not only understand that from a physical side, but also from the mental health side. I think Herm said it during his opening speech on what the impact of being out of the lead can do for our mental health and the impact it can have on the health. So I bet you, if we were to go back and look at response rates and respond here this May, where I think we've now seen a real big push at the society level, I think you'd see a higher response rate. I think it was very interesting if you looked at the average age in that response, it was actually relatively low, and yet you're seeing such high percentages of people with back pain and actual already. So we're not talking about the 60 plus club. We're talking about the 30 to 45 club that is getting injuries already. So, what's going to happen when that increases? And I think the important aspect, and really a tribute to both you and Herms and the whole society, is raising awareness of this. I don't think, personally, even though it said 3% stepped out of the lab for mental health disorders, I bet you it was 0% reported in the past. I bet you we didn't even answer that question, because now people are becoming more acceptable about talking about it. And same thing, we need to talk about this and actually respond to the surveys. I think that's going to be the most important thing.
I'm going to give you a follow-up question, because you really did touch on what my next question was going to be. And that was, I was encouraged by 40% being early, mid-career, 5 to 15 years in practice, a group that historically has not embraced advanced protective gear and radiation reduction. They're in the early part of their careers, much like an early career football player worries about just playing football and not the safety of the game. How important is early to mid-career, not the 60 plus as you put it, but early to mid-career in terms of moving the needle?
I think it's imperative. I think it's imperative not only, and maybe because I'm in that group, but I think it's not imperative because we as a group in that kind of mid-career, early to mid-career, we see people suffering. I mean, I see one of my senior partners already had cervical spine surgery. I see people not wearing lead in the cath lab because they had cervical spine injury, and including a tech. And, he can't feel a couple fingers. Because of that cervical spine injury. So what we're saying, and I've said this at my own institution, we're out of the lab by 2026. I don't care what it takes. We're done. And it's a moral imperative. And I've used those exact terms. So I do think what you're seeing is we're learning. I mean, we're a little slow, but we're learning. And I think the older interventionalists that unfortunately have had to endure years of just being, oh, this is what we do. This is the machismo thing. Oh, we don't have a problem. I think you're going to see here a more and more preventive, what Peter Tia says medicine 3.0 is really kind of moving towards the needle of saying, what can we do to prevent these injuries? How can we get ahead of the game? And that includes, by the way, talking about mental health. Get ahead of the game so that we don't get to the point where we're burnt out. We don't get to the point where we're depressed. But let's also not get to the point where I'm hobbling in the cath lab every day. I don't really want to have chronic pain. I'm gonna leave that one off my list of medical problems I want to add.
That's great. That's great. Islam. Let me ask you something. As I reviewed this paper, just a really excellent paper, it sounded like nearly 20% report essentially that old expression, putting the badge in the drawer, so that the badge readings weren't excessive and you end up having to set it out for a while as an interventionalist. What a calculus here, that internal battle that the interventionalist faces between dedication and drive versus just foolishness. How do you weigh this? How do you look at this calculus that interventionalists seem to prioritize?
I think it's partly momentum. We are trained and we proceed with the usual way of operating, the usual way of working. And we tend to be fairly driven as a specialty. So when something like your radiation, which, let's be honest, you don't feel radiation, you can feel the after effects of it, the skin injury, and of course the cataracts and the unfortunately, all the other consequences that we've outlined. But we don't actually feel radiation. You don't feel warm at the time you're being impacted by it. So the momentum and inertia of our work tends to be fairly unstoppable. One of the things that we found that was statistically significant, and in fact is becoming more statistically significant in this survey compared to the longitudinal analysis, compared to the prior surveys, is that injuries actually increase with age. So the older the person is, the more likely they are to report injuries. That's not a surprise, obviously. But what we also found was that the numbers, the procedural numbers, the complexity of the procedures, everything went up from 2014. So I think it's a matter of momentum. It's not that we're being necessarily, as an interventional specialist, that we're being disregarding or we don't know about this. It's that we have a goal of taking care of our patients and managing our work. And it's very difficult to get out of that mindset because that is, in fact, how we do. This is what we're trained.
Jim, the fact that knee and hip injuries are high, but that the 30% discussed cervical spine and 30% lumbar spine injury. This has got to be near and dear to your heart, based on your own personal experience. Isn't this spinal injury thing really the most concerning, most unforgiving of the orthopedic injuries?
Yes, and I think, compared to hip, knee, etc., there's a clear-cut signal that we're at much higher risk for this with what we do. I'm not so sure the hip, the knee, it's necessarily what we do. Probably the lead increases that, but there are nice data to really demonstrate the cervical injuries tenfold higher, spinal lumbar issues threefold higher, and that's generally what takes people out of the lab. And with other surveys in the past, 50% reported either they were or they have gotten out early because of their spinal injuries.
Yeah, that's very consistent with the ACC survey. And then the most recent survey was the ORSIF survey last year, where 50, 55, 60% of interventionalists say, if this doesn't change, and Andrew said we already have a shortage, but if this doesn't change, I'm going to get out of the lab. Andrew, the idea of malignancies is concerning. There's a cataracts, posterior cataracts concerning, but it seems to me on a relative frequency scale, the musculoskeletal related issues are going to be the thing most likely, the disease process is most likely to affect interventionalists, correct?
Yeah, that's correct. And I think the only way to really do this, and this is, again, SCAI's really led this on various fields, be it multidisciplinary in the valve space, be it in the peripheral arterial space, is the way we're going to fix this is we're going to get together. We got to get together with the other societies that say enough is enough. I mean, I had a meeting with a C-suite who happened to be one of my patients, and I said, look, if I'm out for 2 weeks, that's $1 million loss to your hospital. That's $1 million. You and then say it's going to be 6 weeks I'm out for my C-spine surgery. Add that up, and you can easily pay for a Rampart or Nest or any of these things for all the labs.
Jim, Selena Young has done just a superb job about expressing the concerns of those who are of childbearing age, women of childbearing age, who have been, and the quote from the paper is, discouraged about working in the cardiac catheterization laboratory. In her work, and there were two really beautiful papers that clearly demonstrated that radiation exposure, fluoroscopic exposure during the childbearing years is the #1 deterrent to women going into interventional cardiology. I mean, doesn't it become even a greater moral imperative if our interventional community is not as rich and diverse as it could be?
Yeah, absolutely. You look at the number of women who are interventional cardiologists. We are missing out on this huge pool of talent and brain power. And in many ways, the ergonomics, the way we do our work is what deters more, I think, from getting into this, fantastic profession that we're in. And, the number that would prepare to step out when they're pregnant, 70%, 28% in this, reported they were discouraged from working. Clearly, this is another really gigantic reason that we need to fix this and get the protection out there that everybody deserves. And, when you get to zero radiation and no lead, I would imagine most of those 71% would reverse their opinion about getting in there and working in the lab.
The wealth of evidence and the tangible impact on our profession really has shifted the burden of proof as far as I'm concerned. But prioritizing radiation safety in this post-COVID era, where we're wanting to have protection and balancing that with the cost of having that protection. This is not a reimbursable item, okay? So how do we work that calculus into this, Andrew? It's nice to say we want protection, but something that isn't paid for, isn't reimbursed. How do we convince hospital CEOs that this is important?
So I think there's absolutely, cost is by far the biggest barrier that we have. And I think it's going to take, again, us doubling down, getting together with SIR, getting together with our EP colleagues, getting together with even orthopedic colleagues that are in the operating rooms using fluoroscopy, and all of us saying enough is enough. We need to work on lead-free environments, because from a cost-benefit ratio, if you look at the number of physicians and the cost it takes out, if it's $1 million for the loss of a busy interventionalist, cost of the hospital over a 2-week period, that's a no-brainer for your ROI on that. But making that business plan is going to be important. So I think we have to learn to speak the language, go forward and say, and that's where I think SCAI can make a big difference, because I think we can help provide that language to each of its members and say, okay, go forward. And also, I think we should be meeting with the top healthcare facility CEOs specifically, maybe down the road, or at least backing it up as a SCAI-led contingent with everyone else. Because I think if the CEOs start hearing it, I think it was during that same talk, just get some donors in there, get them to wear the lead, get the CEOs to wear the lead. We'll see how long they last in the lab.
Herms, I want to quote Dean Kariakis, who is near and dear to all of our hearts, and who has had, a very personal experience with this. He said, in the context of workforce attrition, incremental costs related to traveling staff, the post-COVID costs of running a hospital, staff recruitment and retention bonuses, supply chain related vendor costs, and falling contribution margins, the prospect of piling on costs to provide a more comfortable radiation exposure protection for our staff has never been more daunting. He's right about this, isn't he?
Yeah. Oh, yeah. Yes. I think it is clearly, a difficult time to find money for this, but I think the way is a carrot and a stick, and the carrot is, as Drew said, the ROI. Show the numbers, and I think they're going to be compelling. 2, staff turnover is incredibly expensive. I know our staff, now that we don't wear lead, easy to recruit. Nobody leaves. Nobody's injured. We've had, over the last year, had 3 of our staff get spinal surgeries, and then recruiting physicians as well. They want to see this, particularly young physicians coming out. They don't want to wear the lead. To me, that's the carrot. The stick is going to be one regulatory implementation of these are necessary. And we can do that either with legislation or through administration, HHS, or OSHA. So there's, I think, the stick on regulation. And then the stick in the next 4 to 5 years is going to be liability. And that will clearly get the attention of the hospitals when there's a class action suit in those institutions where, they didn't
seem to get everybody's attention, doesn't it?
Yep. And, I always say the answer is money or liability or both. And what is the question?
I want to thank the 3 of you. First of all, Islam, I want to congratulate you on a really well done paper, very informative. Andrew and Jim, thank you for joining us. This has been really a very informative SCAI conversation, JSCAI conversation. So thank you for joining us, and we look forward to more conversations in the future. Thank you very much.